This conference will now be recorded.
Okay, we're going to record the conference. I can hear you. Howard, can you hear us? Everybody hear us?
Yeah,
Yes,
I can hear.
Yeah, I can hear.
I can
Okay,
hear.
great. So, Dr. Ben, why don't you real quick just tell us, because you're on a short time, a little bit of what's going on. And Dr. Ben will be one of our speakers at the conference in April. God bless him for being with us. So,
Thanks, Peggy. No, there's a lot going on in the space of breast cancer, particularly some of the areas of HER2 disease that we were talking about. There's a drug that we just kind of call 8201 from Daiichi that just got FDA approved for HER2 metastatic breast cancer that's
I
becoming.
can hear you. Can you hear me, Peggy?
yeah, who's this? Is that Howard? No. Who was talking just then? Okay, Howard, your microphone's not working. That's all right. Just let us know if you have a question. You can chat with me. Okay.
All
All
right.
right. Go ahead, Dr. Ben.
No, I was just saying this one drug really works well. It's interesting because it's the second drug where we've just used Herceptin, but put a different chemotherapy on it. So the first one was the drug called Kadcyla, and this one is again by Daiichi, and it's called 8201.
I can hear you, but I don't think you can hear me. But thank you.
Can you hear us?
Can anybody hear us? Everybody?
Yep.
I can hear you.
Okay, great. And this will be recorded that we'll share later too, in case you can't hear.
Okay, sounds
Okay.
good.
Go ahead.
So the drug is really effective, and it's interesting because it's a little bit different. That it seems that it has more what we call bystander effect, meaning that can actually destroy cells that are neighboring cells, and that might explain why it might work a little bit better in HER2 positive resistant disease, because if they somehow manage to not use the HER2 receptor per se as their primary source, if it's a neighboring cell that happens to get tagged with this particular antibody, and then the chemotherapy is just kind of a next door neighbor that kills it, that may explain it. Now, it does have more side effects because of that, but it's still not as bad as kind of what we would say naked chemotherapy. The other drug is also really exciting because it's not an antibody or an IV drug, it's a pill. And it's really the first HER2 pill that is specific for HER2. All the other ones before it, lapatinib and neratinib, they get HER2, but they have side effects. They also get HER1 and HER4. So HER2, as the name implies, since there's a 2, there's also a HER1, but there's even a 3 and a 4. And so this one is very specific for it. So it has very little side effects, relatively speaking. It also crosses the blood-brain barrier. A lot of what we've been seeing now in HER2 metastatic disease is that because the antibodies are proteins, they don't go into the brain that well. So we're seeing a lot of HER2 positive patients get brain metastasis of the disease. So we're hopeful that this will actually mitigate a lot of those. And then finally, for ER positive disease, so most male breast cancer is not HER2 positive, although there are some, and I have some patients like that. But for ER positive disease, the majority, I think many on this call know, of male breast cancer, we have a lot of new molecules and drugs that are coming down the pipeline that attack the estrogen receptor. And so a lot of these are cousins with drugs that we already are familiar with, tamoxifen, Faslodex, also known as fulvestrant, but they're all oral, and they seem to have some really good effectiveness for patients who progress on current standard of care therapies. So there's a lot of cool stuff coming down the pipe this year, and I think we're going to see some pretty exciting results and even drug approvals later on.
That's amazing. This is great. And anybody have any questions for Dr. Ben?
Yes. Hi, this is Jeff Flynn. I do have a couple of questions. My first question, Dr. Ben, is did you say that Faslodex was in pill form?
Sorry, I was muted. Faslodex by itself is not in pill form, but Faslodex is a class of drugs that we call selective estrogen receptor down modulators. I don't know who made up these terms, but that class of drugs now has moved forward into oral formulation so that you don't have to get the 2 shots in the butt anymore. So all the new thirds, as we call it, selective estrogen receptor down modulators, are oral. We had one that was in clinical trials a while back, but it failed because it had a really high unacceptable rate of diarrhea. But that seemed to be very specific for that drug. And so now there's all of these new oral SERDs. So again, cousins of Faslodex oral. And they actually seem to work really well against cancers that have developed mutations in the estrogen receptor and developed resistance to drugs like tamoxifen and aromatase inhibitors. So yeah, there's a lot of cool stuff coming down. And again, we'll see a lot of that this year.
Oh, and I'm sorry, doctor. This is Jeff again, and I'm not 100% sure what you're saying. There seems to be some background noise.
Oh, I'm sorry.
But I've been on. I'm sorry. I've been on Faslodex now for about 4 years with Ibrance, 125 milligram Ibrance. You know, that's the 21 days on, 7 days off. And it's been quite effective, but a number of side effects. I go through the pain of having the 2 shots in the butt, and I also, my immune system is on the hairy edge. I've been sick all winter, so just curious as to this oral medication that you're speaking of. Number one, would it be something that's comparable to Ibrance for the HER2 HER2 negative, and is there something in pill form instead of taking the injections?
So I just want to clarify, these new drugs that are oral don't replace the Ibrance, they would replace the Faslodex injection. So you would still take it with either Ibrance or the cousins of Ibrance like ribociclib or abemaciclib. And what we believe is the most effective way to treat breast cancers that have developed resistance to endocrine therapies and have developed the estrogen receptor or a estrogen receptor mutation is to use a combination right now of Faslodex and Ibrance, or again, one of its cousins. Now, we don't know 100% for sure if that's the right thing to do, and certainly you can still develop resistance against that, but what we know from both clinical trials in the lab, right now that seems to be the best combination. And now the question is, can we use the oral forms, or the oral cousins, I should say, of Faslodex with Ibrance or one of its cousins, ribociclib or abemaciclib, to really show that this is going to be just as, if not more effective than, using Faslodex with the other drugs. I will say that these other oral SERDs are not the only new drugs being tested. Even cousins of tamoxifen that are slightly different seem to potentially be able to attack these breast cancer cells that have developed resistance. So again, there's a lot of exciting stuff happening in the field right now.
All right, so my last question, doctor. That is the 8201. That's the oral form of a Faslodex replacement, or potentially.
8201 is the one that's the HER2. It's Herceptin. So this is only for HER2 positive disease, and that has a different chemotherapy kind of payload, if you will, than the current drug, which is called Kadcyla.
Okay, so then what is the replacement called? I mean, I'd like to speak to my oncologist about it.
So they're not available. They're all in clinical trials right now. And so there's a number of them. So most major pharmaceutical companies in drug development for cancer will have their flavor, if you will, of that drug. And so, yeah, I would encourage you to look it up either on the internet and discuss it with your oncologist for the future. You probably won't be eligible since you've already been on Faslodex for a while, because remember, they're cousins.
Right.
So the patients they're going to be looking for the patients who have never seen Faslodex.
I see. Okay, that's for the clinical trials.
Yep, exactly. So none of this is approved yet, but there's been a lot of exciting results that people have looked at and probably will be reporting hopefully later this year, maybe early next year.
Okay, thank you, doctor. I'm sorry to take up so much of the time on this call. Thank you.
No, thank you. All right, so we have Carrie, Dr. Carrie here, and we'd let you go on and get started real quick if there's no other questions for Dr. Ben. Anybody else? No? Okay, so Carrie, let's have you do your presentation.
Okay, so hi everybody. Peggy invited me along to join with this meeting this evening, really I think to share some of the research that I'm doing here in the UK quite in contrast in some ways to what Dr. Ben is doing, which is sounding incredibly fantastic, but from a very clinical perspective. The work that I do as a health psychologist, chartered psychologist, really looks at men and breast cancer and their experiences from a psychosocial perspective, a psychosexual perspective, the way that it kind of affects your day-to-day living, really, right from kind of pre-diagnosis and trying to get a diagnosis of breast cancer through living through that experience, and then kind of beyond once you're in the recovery phase, or perhaps those that won't make a full recovery, how they kind of come to terms with things in a terminal diagnosis sense. So I don't really know how you want me to go about this, Peggy. Do you want me to go right from the top, or the current work that I'm doing, or?
Yeah, sort of explain what you've been doing and the guys that have already participated and what you're looking for further.
Okay, great. So my interest, I think, I suppose, to take it back, really kind of what was briefly mentioned in the bio that Peggy sent round. My interest in breast cancer in men started quite a few years back now, around about 2011, 2012, when I was first doing my master's degree. And we did a very small piece of research as students on a health inequality that could be discussed. And so that was when I started to learn about breast cancer in men, and how kind of unfairly treated men were, and how they were receiving so little attention in kind of the breast cancer arena. And I realized in doing what was an incredibly small piece of work for a master's assessment that this had real scope to be explored further, which gave me then the idea to take this forward as my PhD thesis. So with the kind of go ahead from two willing supervisors at De Montfort University in Leicester, they agreed to kind of support me as I worked for 4 years studying this area from a psychological perspective. And so to date, my PhD thesis was a study of 31 men's breast cancer experiences in the UK. I also collected some data from some US men as well, which I'm yet to use in this same study for obviously contextual reasons. As you guys will well be aware, healthcare in the US is quite different to healthcare in the UK. But for the purpose of the thesis, the sample was of 31 UK men's experiences, some of whom are fully fledged members of the Male Breast Cancer Coalition, and very much consider themselves brothers of your organisation. And essentially what my study did was it asked men to participate in an interview with me where I asked them questions about what it was like to live with a diagnosis, and also I asked them to take photographs of their breast cancer experience so that I could literally visualize and see the breast cancer experience through the eyes of men who are diagnosed with this illness, and what it's like to live with it from a man's perspective. And so quite interestingly, from a psychological perspective, what it demonstrated to me was that men encounter and perform masculinity in quite different ways at different points during the breast cancer journey. Okay, so where it kind of starts off is that in those early initial stages when men are in the sort of pre-diagnosis to diagnosis phase, they feel incredibly threatened and incredibly exposed, quite unsure really about this diagnosis that's being presented to them. Can everybody hear me okay?
Yes, we can.
Yeah?
Yes.
Do stop me at any time if anybody has any questions, by the way. So essentially, in terms of kind of the way that masculinity is encountered and performed across the breast cancer trajectory, it starts off very much in a threatened and exposed format. Men demonstrated to me through their visuals and through their talk that they're in a position of feeling very marginalized, very much at the periphery of breast cancer care, of breast cancer advocacy, not really knowing what to do with, albeit very limited information that they were given about this illness, and kind of where men fit into this picture as a breast cancer patient. And as they kind of slowly progress through the illness trajectory, and they move towards sort of from diagnosis into the treatment realms, they start to exhibit a different style and a different way of expressing their masculinity. So they move from showing themselves as feeling quite threatened and vulnerable to almost protecting or wanting to assert their masculinity more so, to demonstrate that this isn't going to change who I am. I'm still very much a man. I want to put it forward and out there that I'm a man living with breast cancer. Until then, they reach sort of the latter stages of the disease, when actually they start to actually show signs of reconsidering and reconfiguring their masculinity upon the basis of having then lived through this illness experience. So recognizing that although you are still the person that you've always been, your identity is changed by having lived through a breast cancer diagnosis. You know, the way in which you perhaps think about your life now is different to how you thought about it pre-diagnosis, and what you want maybe from your future and going forward, and also how you consider the condition itself. So men were very raw and very real about the fact that until it perhaps became a reality for them, breast cancer hadn't featured on their radar, because nobody was telling them that it should feature on their radar. You know, rareness shouldn't mean a lack of awareness. Okay, the numbers might well be low, but here in the UK, proportionally more men die each year from breast cancer than they do from testicular cancer. So whilst that might well be a very distinct male cancer that we're referring to there, we can't be denying these figures of male deaths. And so in kind of realizing my findings from my work, and recognizing really that what it showed to me was that current approaches for breast cancer care and advocacy very much serve to isolate men in kind of the wider picture. And yes, we have the fantastic work that the Male Breast Cancer Coalition are doing, and some other smaller dedicated charities. But insofar as your large organisations, particularly in the UK at least, it's incredibly alienating still, quite emasculating. You have to sift through a whole wave of pink material before you get any documentation that relates to men and their experiences, or what might be relevant specifically for male patients. And that's incredibly off-putting for men. They don't know where the starting point is to find information, what patient materials are actually going to be useful to them, you know, or completely irrelevant to them. So they very much kind of feel marginalised and at the periphery. And so the work that I'm doing is, I hope, going some way towards kind of changing that. So I'm continuing to output papers based on my PhD thesis. I had one published last year relating to men's experiences of hair loss, and how the hair loss experience for females who develop breast cancer is something that we talk about, well, not just breast cancer, but cancer generally. We talk about how hair loss for women is a huge deal. But again, it's something that is overshadowed from the male perspective. You know, some men are very caring about the way that they care for their hair. It's part of their identity, their physical appearance. And so actually, I think that was where Peggy and I first connected, when there was quite a bit of media attention about that paper last October time around Breast Cancer Awareness Month. And kind of beyond that, really, I've recently started working with a consultant called Mr. Krupa in the UK. He works for the NHS, and he's also a private consultant as well. And we had a meeting last week where we're hoping to look at changing patient resources and staff training materials, so that eventually we might come to work together to create what becomes sort of a male hub for information that is dedicated for men, but it's kind of baby steps and small inroads as far as we see it at this stage. If we can start by changing existing documentation that we have, so that it is much more equal, so that it doesn't just cater to women, but actually it explicitly mentions men, it explicitly mentions information that is relevant to men's needs. And of course, staff training. One of the things that came up in my data was that men felt that staff when they were perhaps going to meetings, consultations, clinics, didn't really know how to handle male patients. They were frequently referred to as Mrs. rather than Mr. when their names were called. Suggestions for certain drugs or suggestions for surgical procedures weren't as readily kind of discussed, or options weren't made available in the same way that they were to women. And men found that incredibly difficult and frustrating. And so these were all the kinds of things that I was voicing to Mr. Krupa, who is working with men kind of at the real face of it, in these clinical consultations. And so he's currently engaging with some breast nurses that he works with on a daily basis to see how we might change things in the Leicester clinic. And actually that's quite crucial, because Leicestershire NHS Trust is one of the biggest trusts, and it also sees, because Leicester, I don't know how familiar any of you are in terms of UK geography, but Leicester is central, it's right in the middle of the country. So in terms of footfall, we tend to get more male patients that come to Leicester's care than we do perhaps other centres. Now, when I say kind of more footfall, the numbers are still small. They might see 4 or 5 per year. Here in the UK, we're looking at roughly about 340-ish diagnoses each year, so just under 1 a day, really. But still, if we can kind of do something here in the Midlands and then roll it out so that it features up and down the country, that would be a fantastic way to start getting some real attention and some real coverage in a breast cancer arena. So I guess really I want to know people's thoughts on that. I have a few other projects that I can discuss, but I've been talking for quite a while, so I'll perhaps let you guys chime in now.
Sure. Are there any questions here for Carrie?
Carrie, that was great. I apologize. Unfortunately, I said at the top of this hour I had a hard stop at 5:30, so I'm going to excuse myself, since this seems like a good breaking point. And best of luck to you. That's great work.
Thank you, Dr. Ben. Anybody else have any questions here? Michael? We can't hear you, Michael. Are you talking? Hold on. I hear you almost. Reginald, Reggie, do you have would you like to ask a question of Carrie?
No, I don't have any questions.
Okay. Well, Reggie, also we have Howard and Michael on the call, and Rick Baca, other fellow brothers. So do a little intro there.
Okay.
And Howard, do you have any questions for Carrie? No? Okay. Yeah, your mic's not working. Sherry?
Yeah, I just actually sent it on a message to Carrie, but I was wondering, I know I've been monitoring our mortality rates here in the United States, which have continued to rise over the past 10 years. I was just wondering how yours are in the UK, Carrie.
They seem to have stayed relatively stable in sort of that same time frame, but we're looking at around about 1/5 of men dying. So if there are something like 390-ish diagnoses, which I think is the latest cancer research stats from 2016, actually 80 of those 390 men died in that year, which is quite a staggering stat, I think.
Right.
And this is largely down to, I think, a lack of awareness and a lack of understanding and a lack of coverage, really, that men can get breast cancer. It isn't something that is readily discussed here in the UK. It occasionally gets a tokenistic mention on the odd TV show where breast cancer is featured. Actually, the Matthew Knowles news story was quite popular here last October when it was revealed via Good Morning America that he developed breast cancer. Good Morning Britain kind of covered the same topic, if you like, and kind of replayed the video that would have gone out to you guys in the US. But no, the mortality rate it's fairly stable up to today's sort of statistics that I'm aware of. I can just see your message actually, Sherry, that you've joined the Walk the Walk, which is great.
Yeah, we did. I've been talking to the people from Walk the Walk for quite a while, and we actually decided that we are going to share resources, join forces, and you're excited. I'm excited. They put a press release together, and I think it's going to be going out the beginning of February. So
that's brilliant. So at my meeting last week, I informed Mr. Krupa about the Male Breast Cancer Coalition because he wasn't aware of the organisation, and I showed him the leaflets and things that you have to download on the website, you know, for the male breast checks, and we were discussing the fact that kind of in the clinic at the moment in Leicester, they don't have those kind of things kind of in the changing areas or the toilets and things like that, and the possibility of maybe introducing those or something very similar to that here in the UK. So it's really good that you guys have got these examples up there that I can show to people here in the UK and say, look what work is being done.
Great.
And how we can kind of build upon this, because I think it's really useful, particularly where you have so many members and there's so many, you know, of the brothers that are willing to share their stories on your website, and to converse and communicate through activities like this we're doing this evening. And it's really beneficial for us to see what's happening kind of with you guys in the US and what we might do here in the UK. Another thing that I have been working on, or that the university that I work for are working on at the moment, is something which is currently called the DMU Medical Forum. So a colleague of mine who she is a lecturer, associate professor in contour fashion design. She developed breast cancer herself about 2 years ago and became aware of how difficult it was as a woman to get attractive post-operative wear and to feel feminine post-surgery. And she set up this forum with 2 of her master's students who had been designing this really, really beautiful lingerie for females. And I went along to the forum evening, which was predominantly about female breast cancer, and Gillian was aware of my work, and she has agreed to kind of look at things to include men as well. So post-operative wears that might be beneficial to men, kind of helping in the sense of, if we think about from a man's perspective, women, for instance, when they're swimming or they're sunbathing, they can wear bikini tops. They have opportunities and ways of kind of covering up. Men don't have that same opportunity. Can you hear me?
Yes, we
Yes,
can hear you.
yes.
Sorry. Yeah, men don't have these same kind of opportunities or access to garments and things that might make them feel a little bit more comfortable post-surgery. So we're looking at ways, or we will be looking at ways as the forum kind of gets bigger and a bit more detailed as to what might be done for men as well as women. And they had some quite big brands actually at this pilot event, which is what it was before Christmas when I went to it. So they had different lingerie companies, big organisations like Marks and Spencer that are in the UK. And really it would only take one of those major brands or major stores to have an option that was available for men, even if it were only available to buy online, or they had one kind of prototype in store. You know, we have to be realistic about companies putting, you know, and brands putting these things forward for men, because from their perspective, unfortunately, they see it from the business angle and what they're going to sell the most of. So of course they're going to cling more to the female numbers. But if we could just get one store to make a difference and then others hopefully to follow suit, that would make such a difference. Just for men to know that there were things that were available to them.
It is the recovery shirt with Sherry Matthews, Healing and Comfort. My husband Bob just had replacement shoulder, and I'm telling you, he has lived and died by that shirt since surgery. And
amen to that.
It's amazing, Carrie. I think I shared that to you in the beginning, but it's on our resources page.
I have seen it, where you can put the drains inside the pocket.
Exactly.
It's fantastic.
It is, even the doctor today who saw it with Bob wearing it to his appointment, she was blown away too. I said, you all need these, so it's been a lifesaver.
It's interesting to see, what kinds of things men would want really. And if we do get to a position where the design departments start looking at things for men, I certainly would come to, back to the coalition and say, what would you guys wear? What would you want something to look like?
Absolutely.
We look at things and yes, of course, the post-operative gown that you guys have on the website is very practical and it's ideal for post-surgery. But if it was something that was, say, more ongoing, like men, for instance, having problems or feeling self-conscious about their scarring, perhaps they could have some sort of like wetsuit material for when they're swimming or sunbathing, or something that's appropriate, that they feel they have options. Because I think this is the difference from my experience so far and where it's having a bit more of a psychological impact. Women seem to have options. Men don't feel like they have options. And any options that are presented to them feel as though they were options that were for women, and you're just kind of being tagged onto it.
Very, very much so. That's a lot of it.
I don't know how the men kind of on this conversation feel about that, but
yeah. Does anybody, Michael, do you have any ideas, or Rick or Reggie? Is that would be something that you all would be interested in? Yeah, Michael's there. Michael's microphone isn't working, so he was trying to say something.
Sorry.
I think we actually have we run the gamut with. I mean, some men are absolutely not opposed to showing their scars. Others, during some of our photo sessions, refuse to take their shirts off, and we respect that. But we also have some men that will go and have tattooing done.
Of the nipple,
Either the nipple tattooing, or they'll actually just get something to cover the scar, some kind of a tattoo that covers it and becomes, like their badge of honor.
Right.
Absolutely. There seemed to be a real kind of, I wouldn't say 50-50, but there was a definite split between the men that I interviewed. Some of them were, when I asked them to include photographs as part of their account giving, I had a number of emails from men that said, are you expecting me to photograph myself, because I'm not comfortable with that? And I said, no, you're photographing what it's like to live as a man with breast cancer, how you see life through your eyes. And they could literally photograph anything, provided that it was in their ethical remit. So I asked them to avoid taking photographs of other people, of children, and obviously explicit imagery and things like that. Some of them wanted to photograph their scars because to them it was a huge talking point and it was a massive part of their experience. For others, they really didn't feel comfortable literally baring their chest.
Right. We've had it both ways.
Other men wanted to show the fact that they'd had tattooing over the top of their scarring, to highlight the fact a lot of the tattoos that they'd had were kind of including a half pink and half blue ribbon, as you guys use yourself, to really highlight the fact that as well as having this scar, I've now got this talking point of this tattoo, which is going to invite questions. And they were quite happy for that. They wanted people to ask them, hey, how did you end up with that scarring? And wanted to talk and to have a voice. I think this is one thing that has come across really, really clearly in my data. We hear all the time, here in the UK at least, men don't want to talk about health. It's a taboo subject. It's off the kind of talking limits. Men are disinterested in their health. They just don't go to the doctors, and they don't do this and they don't do that. Actually, all of that is a complete fallacy. If you give men an opportunity and an avenue to have a voice, they very much have plenty to say about the topic.
Yeah, it's like I said, once I get these guys talking, thank God, and they do, we can't shut them up, but that's a good thing because they're finally getting it out and being able to share with each other what their experiences have been and all. So it definitely helps a lot.
No, I think it'd be really good. I know we've spoken about potentially putting together a resource for men, using kind of my stuff and knowledge from the UK combined with the bits and bobs that you're doing already, and maybe having a kind of corner or area of the website that's sort of dedicated to psychological material. Because at the moment,
absolutely,
that's kind of what's missing, isn't it? When we had a chat about how I could maybe interact with you guys and work with you, giving men an opportunity to kind of consider the psychological components, because yes, of course, the primary concern is always going to be the clinical aspect of treating the cancer, but psychology is so much a part of the illness experience and what it does to you kind of socially, emotionally, sexually, in terms of the relationship that you might share with your partners and your loved ones. And of course, those experiences are nuanced and individual for men, which is why, as well as the work that I've kind of done as the primary body of work with the 31 men's experiences that I looked at, as kind of sort of an offshoot project from that, I'm writing a paper with a colleague at work at the moment on gay men's experiences of breast cancer too, because again, that is an area that is sort of a niche within a niche. It's not looked at as much as it should be.
Yes, we have many gay men and also transgender, so that have come to the coalition. So we open it to everyone. This is what it's about. You want to cover every aspect of it.
Yeah, we need to be thinking about breast cancer going forward in 2020 as an illness in a much more holistic manner, as an illness that doesn't, discriminate per gender, per sex.
True.
Breast cancer, it is not a gendered illness. It is a condition that affects men and women. And it's about time people started talking about it in that context, really.
Very much so. And with all of us, we can keep getting the change to happen. So anyone else have any other questions here for Carrie or what's going on? I'll remind everybody we have the conference coming up, and if you haven't signed up, we want to get you on it. It's going to be amazing this year. Our next go-to meeting will be on February the 20th in February, and then April will actually change it to the week before the conference. But Carrie can't make it, but hopefully we'll get her responding some of our Facebook Live. We'll have you on the Brothers page on Facebook too, Carrie, where you can go on and we'll be live streaming the Facebook live pages for all the conference. So
great. Okay. Well, perhaps I could come and join the April meeting before the conference.
Yes.
And we could have another chat then and see if any of the men have got any questions kind of prior to the conference or something like that.
That would be amazing too. But anyone else have any questions for Carrie or any more that you want to share, Carrie?
I suppose really the message from my end is sort of watch this space. I'm obviously, as you know, liaising with you, Peggy, about things that we can put up on the website. So links to the papers, the academic papers that I've been writing, and perhaps maybe just like a short update every now and again about the work that I'm doing.
That'd be
and
great.
how things are progressing in the UK. And I can either do that in sort of a written sense, or I can come onto these meetings every so many months and just keep updating you guys as to what's going on and how things are progressing.
That would be fantastic. Absolutely.
That actually would be good, Peggy, because then, we've got our guys in the UK that,
Yeah.
can feel more part of this, because a lot of them don't get on these calls.
Right.
And a lot of the information that I disseminate on social media is coming from the United States. And while it's
Right.
good that, it's also to know that, they have somebody in their corner over there that's also doing some of this light work.
Absolutely. And Carrie, have you and Beth Herring ever connected yet? She's actually
Yes.
she's gonna come to the conference. So
Beth is, yes. I had
Yes.
a chat with her and her supervisor, Diana,
Excellent.
just before Christmas, I think it was.
Excellent.
And she's doing a lot of appearance-based kind of research. So there's a lot of my stuff that can really kind of help Beth,
Excellent.
and we're there's a potential in the future there as well for us to hopefully collaborate together.
Well, and then maybe give her some collaboration when she speaks at the conference. She can share us for the UK, the two of you
yeah,
guys.
absolutely.
That would be great.
Yeah, and I have to say as well, not just kind of the researchers and things that are going on here in the UK, but some of the men that are members of the coalition. Doug Harper, he's been fantastic
Yes.
in terms of flying the flag for you guys over here. He's been on various different radio conversations that I've had with local and national media. He's been quoted by that, and I think having an expert perspective or a clinical individual, a psychologist, whoever it might be, having us speak is one thing, but actually having a man that has been through this experience speak
Yes.
alongside you is absolutely vital, and that's the part that people remember.
Very much so. The at the San Antonio Breast Cancer Symposium, Rod Ritchie was there and Kevin Barnes, and when they were able, both of them were there on scholarship, really pushing out male breast cancer. And Michael usually got to attend, but this year he couldn't make it. But it's huge because once the people stopping at the booth, and we never stopped. We had a line 24/7 times we were open. And when they got to finally talk to Rod was from Australia, and Kevin is from Arizona area. The people were just amazed because when they're talking to an actual male breast cancer guy, that makes the difference. It really, truly does.
I think the stories, when you listen to the male perspectives that come through, it's quite, the data that I have is quite harrowing in some ways, because you can't quite comprehend just how discriminatory men have been treated in the ways that people have spoken to them or spoken about them. The disregard for the fact that people refer to this illness as a female disease and how that affects men. One of my patients that spoke to me, he actually had a woman ask him if he thought he got breast cancer because he was a gay man.
Oh, wow.
Oh,
Yeah.
we've had people come up to conferences, not conferences, but in tabling events, and walk up to the booth, and these are older people. You would imagine that they would be educated and understand. And they said, "Oh no, such a gay man." And it's really sad. Ignorance is out there.
It is.
Absolutely.
If you have breast tissue, you can get breast cancer.
Exactly.
And that's what we preach. And I fall back on our story about Eli the orangutan, 2014. He's on our YouTube channel. Died at Salt Lake City Zoo at age 26 of male breast cancer. People, it can happen to anything, I should say, if you have breast tissue. So.
Yeah, it's quite shocking for me, the level of, as you say, Sherry, the level of ignorance surrounding it. And also, I've been in presentations as a PhD student, I can remember giving a micro. We had to give a micro session, so it was like a describe your PhD in 5 minutes, and I obviously spoke about the fact that men get breast cancer, and one of the questions at the end was, "Is this a joke?"
Oh yeah, we get that all the time.
And
I
I
walk
was
around
like,
with my shirt on, and people look at me, is this a joke? And I go, no, it's real. That's what you got to get, you know?
it's just astounding
Yeah,
that in 2020, you know, this isn't more mainstream. And I think the work that you
exactly.
guys are doing, the work that I'm doing here in the UK, people like Beth who are continuing to do kind of PhDs on this topic is so, so vital.
Very
Um,
vital to help keep it out there. And when the
mhm,
TV shows like A Million Little Thing has come on and has an actual male breast cancer Gary survivor on the show, and that's part of their storyline, that's helped. I hate it that Beyonce's dad, Matthew Knowles, got breast cancer, but guess what it did for us? I mean, it brought us to the forefront again, that this happens, and men can get breast cancer. But it takes the celebrity status to finally continue to get the word out.
it is a shame, but you know, it's undeniably that got attention in the UK for sure because it's
Everywhere.
Beyonce's dad, you know.
Right.
And it did it made people kind of stand up and say, "Oh, okay,
This is
so
real.
this is
Yeah.
a thing. This is
Yeah.
real." Yeah.
And I mean, I could be shopping for groceries in our wholesale clubs here, and I wear the shirt, and they'll stop and they'll start talking. Oh, that's such a neat shirt, and I go, well, it's real. My son, you know, I tell him is a survivor at this point, and the men that ask me will look at me and immediately start checking their breast in front of me. That's what I love, because immediately you've gotten the man's attention. Oh shit, this could happen to me. I better make sure, you know. And that's what, with all of us, as I say, together we will change the world. That's what it takes. That's totally what it takes. It takes every one of us getting the message out there.
Yeah, absolutely. Absolutely.
So is there any other questions here that anybody has, or any questions about the for Carrie and or the conference, or any other things you'd want to bring up? I don't know.
I just wanted to thank you,
Go ahead.
Carrie.
Yeah, Reggie, go ahead.
Oh, I just want to say thank you, and this is my first visit, and I'm glad I came in and joined you guys, and I'm really feeling great about this.
Well,
Oh,
we love it, and
Great.
we say welcome to a family not one damn one of us wanted to be part of, but since we
Right?
are, we're going to make the
Yeah.
best of it, because God's teaching us on how to teach the world, and
Right.
that's what it comes down to. So just know we're here for any of you guys, no matter if you
Okay.
want to share stories or not, or you need to text me. You've got my cell numbers right there at any time. If we don't have an answer, we'll find it out. Okay, we'll keep searching until we do. So just know we're
Okay.
here. We're family, guys, and like I said, we're here for each other.
Okay.
Carrie, this is Rick Davis. I don't know if, can you hear me okay?
Yeah, Rick, we can hear you.
Yeah,
And
I can hear you, Rick. Yeah.
He's Ancan, our host of all this. So
Oh,
great.
hi.
So we host it, but I'm very curious. Are you still working out of the UK? And if so, where are you working out of?
Yeah, I am working in the UK. I'm a lecturer at De Montfort University.
At where?
De Montfort University, which is based in Leicester, in England.
Which is in Leicester. Okay. Okay. I've had my closest friends. I was tiny. Just retired on the 31st of December as a breast cancer surgeon. He was one of the leading breast cancer surgeons in the UK. He worked out of the Royal Surrey, and
Okay.
I talked to him about some of his patients, some of his male patients. He hasn't had a lot, but he's had a number of male patients. I just wondered if you were down south, you probably haven't run into him if you work out of Leicester.
No. So, I'm based in the Midlands, so he would be a little bit further south than me. But
That's
the
right.
consultant that I spoke to, who is based in Leicester last week, he said, you would be lucky being the wrong word, but lucky if you came across maybe 4 or 5 men in your career as a consultant in the UK. And actually, this chap that I have been meeting with at Glenfield, he has actually seen double figures now. So he's very well versed with male breast cancer, which I think makes him the perfect person, really, to start kind of understanding things from a clinical perspective with. We're kind of hoping that with my psychological knowledge and his clinical knowledge, we can meet somewhere in the middle. And really kind of start pushing things forward from a UK perspective. But yeah, I'd be happy to learn more about your friend and the work that he's done.
Well, his field actually was sentinel lymph nodes. That's where he published most, which is pretty well known. And I talked to him about male cancer. Male breast cancer. Like I said, he literally just retired, and I've been trying to get him interested in something to pick up as a cause, and this may be a possibility. So, Peggy, if you connect us,
I will connect you via email. Yep, already.
Yeah, connect us, and then I'll connect you, Kerry, to my buddy. His name is Kiffin, Mr. Mark Kiffin, Kissin.
Could you write that in the chat box for me, please, Rick?
I'm in my car right now.
Okay,
oh,
yeah.
Sorry.
All right, I just sent you
the
email. I just sent you an email, so the two of you connect.
Yeah, I'll take care of connecting you. And I know he's interested in the subject. I mean, because we've talked about possibly setting up a similar group to this for the UK because the time is so bad.
Yeah.
It's the middle of the night, and I'd like to set up a group in the UK for male breast cancer if we can. And Mark said he may know somebody that would be interested in moderating. So maybe between all of us, we can get something going, and with Peggy's help too, because I know Peggy has one or two people from the UK, right, Peggy?
Yes, that's correct. We do.
That would be absolutely fantastic, and I think it would be something that would be very welcomed here in the UK from the members that I understand that have, connected with the Breast Cancer Coalition already. They would very much have welcomed an opportunity. It is, as you quite rightly point out, it's very late here. It's nearly midnight, and that's fine for me because I'm fit and healthy and young. But if you're not very well and you're undergoing treatment, you kind of need it to be at a time that is accessible for you. But that's not to say that occasionally maybe we could combine the two and we could have kind of the UK and the US one that merge together. That would be fantastic.
Oh yeah, we can sometimes change the time. Absolutely.
Yeah,
that would definitely work.
Yeah. I know how bad the time is, Kerry, because when I'm visiting with Mark, I moderate meetings. And so I have to stay up from anywhere till 11 till about 1 a.m., 1:30 a.m. to start the meeting. So I am very empathetic.
Thank you. I'm delighted to be invited to speak actually by Peggy. So, it really doesn't matter to me how late it is this evening. I'm delighted to be able to share with you what I'm doing. And I hope you've kind of found my input useful this evening.
Yes, absolutely. It's excellent. We can't thank you enough. And then for February 20th, mark that on your calendars, guys, but we'll keep reminding everybody. And I would love to see as many faces as we can here for the conference, April 23rd through the 26th in Kansas City.
So just remind me, Peggy, it's April 23rd to 26th for the conference.
Right.
And what were the March and April dates for the go-to meeting?
The February meeting's the 20th, and then the March will actually be on, hold on, It will be on March 26th.
Okay.
And then April will actually be the 6th. Hold on, the 16th is what we're going to move it to.
Okay. So
Regularly, Carrie, regularly it's the fourth Thursday of the
Yep.
month at the same time. I have to work. I've got to check the 16th for you, Peggy, but we'll figure out a date for you for
Okay.
for April for sure.
Okay, that'll work. That'll work. We'll get that out to everybody.
Brilliant.
Excellent. That'll be great.
Okay.
All right. Anybody else have anything, or we'll close out for the night? We've had a great call. It's been an hour. That's everything.
Yes.
Everybody have a
Can
great
I-
one. Yeah,
Are
go
you
ahead.
Can I, Peggy,
Yes.
before you leave, can I just put in a plug
Absolutely.
for the guys? The first Thursday of the month, that's the Thursday before this one, at 8 o'clock Eastern, so start a little bit later, we have a group called Speaking Freely, which is a group for men only with any type of cancer.
Okay.
And it's peer-led, and we'd love to see some male breast cancer guys on that call.
Okay,
You
I
are
shared
very,
them
very
out,
welcome.
and I will keep sharing them out. So, excellent.
Yay. Yay. Thank you.
Excellent, guys. Thank you again, Rick, for making this possible. And
Oh,
Carrie, we
my
can't.
pleasure.
Yeah, Carrie, we can't thank you enough for enlightening us, and we'll keep everything going. This will be great.
Brilliant. Great talking
All
with
right.
you guys.
All right. Talk soon.
Thanks,
Bye-bye.
everybody.
Go,
Thanks,
Fox.
Carrie.
Go Chiefs.
Foxes, Carrie. Go Foxes.
Yeah, that's right.
That's right.
Excellent. All right. Bye-bye.
Bye-bye.
Bye.